All right. Well, hey, thank you, Mark. I really appreciate you. You're helping us here with the maiden voyage.
Very good.
So we're here with Mark Young, CEO of My CHN.
My CHN, yes.
My CHN. Yeah. So thanks again for joining us. We're back talking about innovation here at the Becker's CEO CFO Roundtable. You're a CEO.
Yes, sir.
And you've been doing some things over the years in the column of transformation, innovation, and you have your own passions. We were talking. So just share, what is it that you think is ripe for innovation? What do you want to transform? What do you want to drive these days?
Well, everyone we serve is different. Some people have a lot of technology capabilities. Some people don't. In order to make it work, we have to shift as much as we can to people who embrace technology.
Yep.
So I think we have to build systems that work for them in order to leverage our resources to be able to focus more on the people who can't use those technology tools.
Yeah.
So That's a big piece. I mean, we don't look to leave anybody out.
Yeah.
But we know that there's a large group of folks that are pretty in technology capable, especially if we can take on a very user-friendly access.
Sure.
So if we can do that, it really, it's what we have to do, especially in a market where human resources are a premium, where anywhere we can shift the need for someone to manage that delivery is just imperative, because there's just not enough resources to do it.
Absolutely. Yeah, and as a federally qualified health center, you're probably good at grants.
Yes.
And having to be, you have the challenges we were talking about. Maybe you can share. What are the challenges of having to innovate when you're on a fixed budget?
Yeah. Well, for us, it becomes more important to actually do it. I mean, we all have to be looking into analytics. We all have to be looking at development. We all have to be looking at tools that move us into the next levels.
Yeah.
But the problem for a lot of FQHCs and other smaller nonprofit organizations is that if we outsource all of our technology needs, well, we're also going to cut deep into our ability to open up more care for people.
Yeah.
So it was important for us to do our own development, and I think it's really starting to show a huge return now over the years.
Yep.
That being able to, we started off working on our own electronic health records 7 years ago. We took an open source product, and it's pretty, in many ways, not as recognizable as it was when we began.
Sure, yeah.
And then when COVID first hit, we remained very open and promoting access to care for COVID testing.
Yep.
Well, the overwhelming response was not enough phone lines, not enough people to answer phones. It was just an incredible tsunami.
Yep. Yeah.
that hit.
Yeah, sure. Yeah.
And so we had to make adjustments, and we opened up all kinds of opportunities through our patient portal. And it just blew up. And it was like it just got accepted. We were able to schedule folks, fully automate the process for them, where you're going to go, what time you're going to be there. We then did the same thing for event management for immunizations. And so after we were able to complete this, we knew there was a lot more we were capable of on the technology side. So from there, we've built our own Bluetooth-enabled remote patient monitoring program.
Yeah.
We have our own internal chronic care management system. We have a integrated telehealth in our electronic health record now as well.
Yep.
So we built another tool that's really interesting. It's not quite finalized. It's a resource management tool.
Okay.
So basically, it's the brains of our services. It'll have all of our credentialing, our privileging, our staff provider scheduling.
Yep.
Our scheduling for all of our staff is in here. So it is a driver for our comm center as well as our electronic scheduling.
Yep.
it's the brains behind all of that.
Yeah.
So it's in getting near finalization.
Yep.
And then we have another project that we're getting close to done. It's our new customer resource manager.
Okay.
And so the CRM is really exciting as well. So instead of our, the rest of the interfaces don't change rapidly. Electronic health records, for us, electronic dental records, any of this, that doesn't change rapidly. But we can create a CRM, customer resource manager, that can bring all the pertinent picture to the person that needs that information. And it can be created multiple times over and over based on what they need to see in order to engage a patient and take care of them.
Yep.
So we're going to start with our comm center and our front desk staff, and they'll have this bidirectional information that they can then, instead of clicking through multiple fields or multiple pages, they'll be able to see all the pertinent in a very limited space.
Just in our discussions, and I think about like your comment earlier around, when you are shifting most of the dollars to the clinical side where they should be, and you're almost forced to be lean and mean and agile, and so sometimes the smaller non-for-profits, to your point, are better because they have to get things done with the fixed budgets that they have.
Right.
So I was going to say, what stories can you share, right, around just being lean and efficient, and focusing on getting stuff done,
right?
Not being too fancy, not being too theoretical. Just like I sense a lot of brass tacks.
Right. It's every day. It's every day. Who's doing the work? What is the need? And are we under resourced? Are we over resourced? What can we do? What can we do to help that worker get the job done? So it's everything. It's in confirmations of appointment confirmations.
Sure.
It's in there's just so many areas where we can focus on every day that does focus on that lane. Right now we're looking at referrals. So we've created a new internal referral management system in our EHR, but now we're moving into this second level where we're going to index the different needs as far as payers, location, the different referrals that you're going to accept. And we'll use this as a simple database. I mean, pretty much it's a simple filter database to help you pick who's the best solution for that patient. It's not rocket science.
Yeah, sure.
Yeah. So there's just so much we can do to we should always be focused, wherever there's labor intensity, what can we do to reduce that? So we mentioned that we're making our foray into artificial intelligence. So we found a vendor, and what we're going to do first, we're looking to use upload imaging on insurance cards and driver's licenses to index the important data and try to really get cleaner data, which we've had struggles with many times.
Yep, I know that world.
So our goal is that this is going to be machine learning.
Yep.
It's going to improve, and we're going to get better data, and it's going to save us a lot of effort, especially on the billing end.
Yep.
That if we get this clean, and then we have our other relationships where we're pulling information to from the copays for the patient and what their estimated cost is.
Yep.
All of these things, and it's all going to come together. And ultimately, we hope that soon, for people who are technological savvy, that they can go through this entire process from beginning to end until having the provider encounter, and we won't really touch any of that data. It'll be hopefully most of it will be there and complete.
Yep, that's awesome. And innovations can be expensive. You always have to measure efficacy. How do you measure, efficacy or efficiency, or what's your system to kind of be honest with yourself that you're innovating, you're moving the needle?
Right.
Right.
I look at I mean, I keep it simple. I
Yeah.
try to.
Sure.
You know.
Yep.
What is the salary cost? What are we going to do? I mean, we may have a year upfront effort to really innovate and bring a lot of innovations. What is it going to be on the back end as
Yeah.
far as long-term savings?
Yeah, looking over
And
time.
I think it can be very, very significant.
Yeah.
And so it's a pretty simple sum to me, and just even the fact of, you know, and even if from a human resources perspective, you know, if we're losing
Yeah.
a few $1,000s a day because we're not getting our confirmations done for our patient visits,
Yeah.
well, then it makes sense to bring in people, additional staff, if you don't have the technology to support it.
Yep.
You know, so it's just a simple equation all in all.
Yeah.
Yeah.
And then how do you know when to cut something that's not working?
Once you know, I mean, I think there's a difference between what's not working
Yep.
and what hasn't been implemented correctly.
Yeah, sure.
So,
Sure.
I mean, we recently put an auto scheduling system in place because we were having issues with patients getting rescheduled appropriately for their follow-ups.
Yep.
So we put an auto scheduling in place. We've turned it off temporarily, but I don't think it's over. Because I think what we failed to do was to work better with the patient at the time of the auto scheduling to confirm with them and make sure that it works for them. So, and that's
point,
another thing we want to see as we move forward with AI. When we look at our patient history, their work, their experience over the last few months, hey, looks like Tuesday at 2 o'clock is a great time for you. Is that going to be a good time? So we'll hopefully use AI soon in that way as well.
You bring up a good point that, you know, we've done work over the years with chronic disease and building clinical apps that are in the hands of a patient. And the one thing we learned is the true power of patient focus groups.
Oh, yeah.
You know, when you sit down with the patients and you include them in the innovation, you say, hey, this is what we're going to build. Here's how it's going to create value for you. What are we missing?
Right.
You kind of let them get their fingerprints on things. There's a big difference when the patient is involved in something that is going to be part of their.
For
do you
sure.
do the same thing?
Well, right now most of our work is driven internally in our revenue cycle management, wherever it may be.
Yeah, sure. Sure.
So we did recently complete the phase 1 of our first patient app. So we have a patient app.
Yeah.
We still should consider it in beta.
Yeah, sure.
So it's being used by people who are coming to us. They're aware that it's still in production.
Yeah.
This first phase was very bread and butter.
Yep.
I think as we move forward into the wellness and area, then we will definitely be looking at a lot more patient focus groups and a lot of patient engagement on that end. Yes.
What are some of the use cases that you're focused on in this beta? Like, what is the UI for the patient?
Currently, right now, we're working on self-scheduling with their providers.
Yep.
They can access their records. They can schedule for pharmacy refills.
Yep.
So a lot of basic stuff.
Things
right there. Just
light
basics.
touches that.
Yeah.
Patients are used to having consumer experiences with apps. You're trying to make it easy. Like, hey, I need a prescription.
Yes.
Boom. Click a button.
Yeah. So we've gone in and we can do they can self-register through either the portal or the app. They can schedule their appointments. They can get their medical records. They can review their labs. They can, schedule pharmacy refills. But coming soon, we're going to move into a lot more wellness, behavioral health, wellness services.
Yeah.
We also are moving into functional medicine. We got some really good partners for functional medicine we're looking at. It's very exciting. And so we want to bring all of that into this experience. And of course,
are you integrating behavioral health like right into the PCP function?
We already have that, the whole person care already.
Okay. Great.
We have a lot of that ongoing. Yeah. We also have oral health care in our clinics. So a lot of the other is virtual, but in our clinics we have even
dental and
hygienists and dentists embedded into the system.
Oh, that's great.
Yeah.
Perfect.
So, but it's going to be the wellness and that area because again, we want to make that available to people, because wellness services aren't necessarily readily available to low-income uninsured people. So we're trying to democratize that and bring that, and that's what technology can do. Technology can really make a lot more available to people. Yeah.
I've talked with a lot of folks in the use case you just described around gamification. Are you thinking about that? Like, how do you, there's smart gamification, even the way that Fitbit and things like that we're all wired, do a few more steps,
Yeah. Oh, it's definitely there. It's still, we haven't put that in place, but it is something we've had a lot of discussion on. And it can work in behavioral health services in any place. People are, they like to be, they're competitive. They like to make achievement.
Yeah.
So it's a really great
classic peer pressure.
Yes, for sure.
Yeah, that's great. Where would you like to be if you just go out like 3 years? What's on the horizon? What do you want to tackle from an innovation standpoint?
Well, eventually, I think we want to ensure that people, wherever they're located, if they live although we're in a metropolitan statistical area, one of our primary counties we serve, where the majority of our clinics is very rural in nature. So there's a lot of folks that live in very isolated areas of it. It's a large county. It's
larger. Alvin.
Yeah, the Brazoria County. Yeah. So we have a clinic in Harris County, which is Houston.
Yep.
We have majority of our clinics in Brazoria County, which is just south of Houston.
Yeah.
And then we have Galveston County, which we have a couple of clinics.
Sure.
So, but Brazoria County is very, although it's considered metropolitan, it's very rural in nature. And so there's a lot of folks out there that you've heard about social determinants of health, right?
Oh, sure,
so,
of course. Yeah.
I mean, it's huge in this population.
Sure.
They're isolated, they're in food deserts, they're medical deserts.
Yep.
There's just so many things that are lacking for them to access care. So we're moving more into at-home services.
Yeah,
we're doing more delivery at their homes, a lot more telehealth, a lot more telemedicine, and that's where we're going to be headed.
Love that. We're involved in some work right now with folks that are enabling the medical homes and in some pilots, and it's just so exciting. It feels like it's still early and nascent,
right?
But you can, if you've got a smart TV, you can leverage the TV as a dashboard. There's so many ways to convert the home into, the place that the patient wants to be.
Right.
Yeah. Okay, so operationalizing determinants of health is big on your horizon. Yeah, makes sense.
We've been doing it.
Not the easiest thing in the world to do either.
Yeah, we just started a few years ago. We went in a partnership with the Brazoria County United Way, and so we co-funded a platform. That platform is being the owners of the platform are pulling it this year. So December will be it won't be available anymore.
Okay.
But we're building our own platform now, and we'll be using the same data tables and everything.
Okay.
And I think we're going to make a lot of great improvements on it. So it allows churches to access and make referrals.
Fantastic.
We can make referrals to home care services or whatever. So any partners can communicate and make referrals through this system. And plus, there's a full social determinants of health surveys done for the patients to identify everything. So it's been a neat program, a little underused for the last few years. Of course, COVID. You can blame it for everything, right?
Oh, sure, yeah.
But when we move forward, I think it's going to be a lot more user friendly and I think it's going to be a lot pretty exciting.
Is there just a metric or a KPI along those lines that you think of? Like 3 years from now, I want to move the needle with smoking cessation or...
Not necessarily. We follow, we especially look at our diabetics that we're taking care of. We look at hypertension patients. We do measure smoking cessation. We have a lot of metrics that we follow. As a federally qualified health center, there's a lot of quality metrics we look at.
Yeah.
And now I don't know if I mentioned to you, we're becoming we're evolving and also becoming a community-based, certified community-based mental health center.
Oh, great. Yeah.
So that will be in conjunction with the federally qualified health center. So we'll be expanding our behavioral health services as well.
I was at a conference last week in Philadelphia that was very, very focused on mental and behavioral health. And it was great to see so many leaders passionate about it, putting their money where their mouth is and investing in it, like setting up funds that are very specifically going after driving improvements.
Huge need. We went from, I think in 2019, before, I think we were serving around 900 patient visits a month for behavioral health services. And this year, several months, we've been at 4,000 visits a month.
Wow.
And behavioral health is a challenge because establishing patients is more challenging than and managing them in ways than establishing or managing medical patients.
Absolutely. Sure.
So it is and in today's environment with the challenge of human resources.
Oh, sure.
It just compounds
labor shortages.
Yes. Yeah.
You're just always having to do more with less. And
and
that brings it, we talked a little bit about automation. So automation is an area like if you look at traditional revenue cycle automation, lots being done to automate, using bots for very specific things. Are you thinking about anything like that in your universe?
We are. We will. We want to use them sensibly. We don't want to.
Sure.
I hate waste. I hate waste for me. I hate waste for a patient.
Yep.
When I first started working in this world, and then people were referring people to a place you knew they weren't going to be able to access.
Sure.
And I thought, what a horrible thing to do.
Yeah.
And I just thought, anything that doesn't have a purpose. Shouldn't exist.
Well, boy, your lips, God's ears, right? It's like,
well, nice to think, right?
There's a lot of, we could have a whole other discussion about that too.
Yeah.
But we all have to tackle waste. It's $1 trillion a year.
Oh yeah.
In clinical and administrative waste, which is just, not good.
Right. No, it's not. No.
There's a lot of other words I could use, but I'll just go with not good. But hey, that's why we're doing this stuff. Any final thoughts or question I should have asked you?
I'll just say that, based on what our discussion earlier was that, when we first started looking at population-based healthcare, and we talked about using data to change population health, and I first started seeing that, and I just didn't really believe it was going to be possible.
Yeah, sure.
Because it wasn't there, and there weren't any tools to do it.
Yeah, absolutely.
And so now that we're seeing, and we can see it, and we got our hands on it, I think our biggest challenge now is still turning the data into a story.
Yeah, absolutely.
That's the real challenge right there. It's like it's cool, and you see changes, you see measurement, but you don't still see it in that full picture that tells the story.
Yeah, we call it about like an insight, efficacy. It's like there are going to be 100 metrics on something, but there's usually 10 that move the needle that drive the most value. Classic Pareto principle, right? So it's easy to be overwhelmed by too much data. So it's like it's getting those leading indicator insights.
That supporting data might be more of where you need to deep dive to understand what's having an effect on your primary indicators.
Yeah, I like the way that, I think it was CMS that, that it was either CMS or somebody else that thinks about the idea of like super measures. You have 100 metrics, but that can be too much.
Oh yeah.
And maybe it's okay to measure all those things, and that's democratized throughout the organization. But the leadership team should be focused on the super measures. that really, because if you got more than 10, it gets tricky.
Oh, yeah.
You know?
Oh, it's very difficult to manage. And hopefully, if you have the right 10, then the other ones are going to be doing better or well,
Yeah.
you know?
Yeah. Well, you create efficiency, and then that can fund
Yes.
working your way down the chain.
Exactly.
All right. Well, it looks like our time is coming to an end. So thanks again. I
Thank you.
really appreciate
All
the
right.
time, and look forward to staying in touch. And good luck in all of your innovation adventures moving forward.
All right. Thank you very much.
Yeah. Thanks, Mark.
All right.
Yeah.
Bye-bye.
Cheers.